And now let's move on to another key event of today's program. Ladies and gentlemen, we are about to move on to another key event of today's program. And now we witness the procession of council members accompanying the orator of Professor C.C. De Silva Memorial Lecture on Women and Diabetes, the Sri Lankan Perspectives for the 21st Century, Professor Chandrika Wijeratne, the Vice Chancellor of University of Colombo. And now I would like to cordially, respectfully invite the following dignitaries to the head table. Professor Chandima Vikramatilaka, President of Nutrition Society of Sri Lanka, and Professor Chandrika Wijeratne, the Vice Chancellor, University of Colombo, our orator. I cordially invite Professor Chandima Vikramatilaka, President of the Nutrition Society of Sri Lanka, to introduce the orator of Professor C.C. De Silva Memorial Lecture.
Good morning, ladies and gentlemen. We warmly welcome Professor Chandrika Wijeratne, the orator of Professor C.C. De Silva Memorial Lecture for annual scientific sessions of the Nutrition Society of Sri Lanka 2021. Professor Chandrika Wijeratne graduated from Faculty of Medicine, University of Colombo, and she completed her MD in Medicine at Postgraduate Institute of Medicine, University of Colombo. She serves as the Vice Chancellor, University of Colombo. She is a senior professor in reproductive medicine with a focus on women's health. She was the Executive President of Asian Universities Alliance for 2019 and 2020. She has held many positions in prestigious professional bodies. She was the President of Sri Lanka Medical Association in 2017 and was the President of Ceylon College of Physicians in 2007. She was the President of the Endocrine Society of Sri Lanka during 2004 and 2006. Her research interests are on obstetric medicine, gestational diabetes, and polycystic ovarian syndrome. She has conducted many research in the said field with international collaborations. There are many high-quality publications to her credit. Her work has been recognized by many awards. She was the Laureate Awardee of International Excellence in Endocrinology of Endocrine Society of USA in 2017. Professor Chandrika Wijeratne is committed to leverage the University of Colombo to be a worthy national think tank for Sri Lanka's economic regain. She is devoted to steer the University of Colombo in COVID-19 era to be self-reliant in education and upscale research and development. And she is she is dedicated to promote multi-sector and regional coordination related to higher education. Further, she is dedicated to achieve optimal health status and food security in Sri Lanka and South Asian region. We are privileged to have you, Madam, as the orator of Professor C.C. De Silva Memorial Lecture for Annual Scientific Sessions 2021. Based on her vast experience in the field of obstetric medicine, gestational diabetes, and polycystic ovarian syndrome, she is going to talk to us on women's and diabetes, the Sri Lankan perspectives for 21st century. Dear Madam, we are very honored to have you today as the orator of this memorial lecture. I cordially invite you to accept the medal and deliver the memorial lecture.
Thank you very much, Madam President, for that very generous introduction, which I'm humbled by. President and members of the Council of the Nutrition Society of Sri Lanka, past presidents, members of the family of the late Professor C.C.D. Silva, my teachers, colleagues, members of this esteemed association, distinguished invitees, ladies and gentlemen. We are gathered today to honor with gratitude a great Sangha of Lanka. Chamli Chalmers de Silva was a pioneer pediatrician, teacher, mentor, and visionary who had a wide-angle view of societal issues related to mothers and children. Can I have the slide projected, please? Is it shared? Yeah, thank you. Although I have not had the good fortune of being his student, I was fortunate to be associated with some of his pupils who had nothing but wonderful things to say about this gentleman. I do hope that I am not too presumptuous to also consider myself privileged to perceive some commonality of Professor C.C.D. Silva's biography and my exposure, particularly in my career path, that are serendipitously linked in history, geography, and clinical exposure. I dedicate this lecture to Chamli Chalmers de Silva, who served this country as the first pediatrician, professor of pediatrics for 17 long years, from 1948 to 1965. Being born on the 24th of February 1905 in Nelidith, Bambalapitiya, his mother was the daughter of the great Charles Henry de Soisa, the philanthropist. My current workplace, the College House, and its recent renovations enabled me to have the good fortune of getting to know the fourth generation of this amazing family. His father, Dr. W.H. De Silva, was the first person from then Ceylon to qualify as Fellow of the Royal College of Surgeons of Edinburgh in ophthalmology, although he unfortunately lost his father at the age of 4 years of age in 1908. Afterwards, he had lived in this house called Alfred House. I believe it's in Alfred House Gardens. And you can judge by the proportions of this mansion from out and in as to what kind of environment he spent in his formative years. He had started his basic education from kindergarten at Bishop's College and then moved to Government Training College in Colombo and later to St. Thomas's College in Mutwal. And in 1922, exactly 99 years ago, he had entered the Colombo Medical School, then called the Ceylon Medical College, from where he proceeded to the UK to get his licentiate to practice, the MRCS and LRC. And then subsequently in 1931, he had obtained the MRCP and the Master of Surgery in 1938. So it is noteworthy that our Faculty of Medicine, which celebrated 150 years last year, Faculties of Science and Arts just a few days ago at 100 years, helped to rekindle our minds to what kind of life that the young C.C.D. Silva spent in his prime days. It is noteworthy that he joined the Faculty of Medicine in the year of our independence as the first professor of pediatrics. Main clinical interests being nutritional disorders, hemoglobinopathies, particularly thalassemia, and infective diarrhea. So nutrition and the community pediatrics were very close to his heart. And he was instrumental in establishing this convalescent home in Thalagolla Ragama. I think it's next to the Ragama Medical Faculty. It's run by an independent trust. It has been used as the benchmark for the WHO to take on this concept of managing acute severe malnutrition, as I have been told by, this was shared with me by Professor Pujita Vikramasinghe, a former orator. Now, this Thalagolla home is a place that I visit quite often with my medical student girls for women empowerment and along with Zonta Club to celebrate Aurudu and Christmas. And that is because the late Dr. Stella De Silva, a colleague of C.C.D. Silva's, was the one who handed us the baton to handle this and help run this place. So it is very serendipitous that I am associated with you to celebrate this gentleman. I also understand that Professor CC spent quite some time at the Disorder Hospital for Women, where I was born, as well as where I work. So that is also amazing, although I did not quite know him as such. He was unique among medical giants in his era and one of the great pediatricians of this country who did yeoman service. He was greatly influenced by philanthropy, and this obviously was ancestral, and he was devoted to a professional life for the welfare of underprivileged children and obviously their mothers. He was a teacher, clinician, researcher, and I feel privileged to have heard from his own pupils who even in their advanced years used to interact with the gentleman, Professor C.C. de Silva. I have watched them. They treated him more like a friend or a confidant, which are the true characteristics of a good mentor and a guru. Professor C.C.'s contribution to scientific literature has been immense. He has published, and those are the days of typewriters, not computers, no digital information. He had been a prolific writer, both scientific and non-scientific, and has left a legacy of amusement to his students and children. So, ladies and gentlemen, I am very humbled to dedicate this lecture to the memory of this great man, a true son of Sri Lanka. Women and Diabetes, Sri Lanka's Perspectives in the 21st Century. Let me declare that I have no conflicts of interest in relation to this presentation, but I would also like to say here that safe motherhood is something we take for granted these days in the 21st century, where women thankfully do not succumb to hemorrhage, sepsis, and eclampsia from seizures. And where at this disorder hospital, where the halls of learning have been and the corridors have been graced by people like the CC, that has left a legacy, and it's taken for granted in today's day and age in terms of saving mothers, that no woman should die when she tries to have a baby. So let me, at the end of this presentation, try to convince you that the 21st century women are indeed at risk of overweight and obesity, metabolic syndrome. Some of them may show the features of the polycystic ovary syndrome, which is a female manifestation of the metabolic syndrome, and early onset of diabetes and cardiovascular disease, which is something we don't perceive on our day-to-day action. And in the context of prevention and control, that pregnancy is a window of opportunity to safeguard our next generation. So this is a photograph from the internet. And I wonder whether at the end of this lecture, whether any of you would opt for either of these two babies. The one on the left of the screen is a cherubic huge Hercules, who is full of body fat, full of thick blood, and probably less oxygen going into his or her brain. While the other one, whom I would call a Hal Massa, is active, lacking in subcutaneous fat, etc., but has suffered and become a small for date. I would also like to mention that I think our small for date, low birth weight incidence is about 17%, and it has been stuck there, maybe for different reasons over the centuries. And I would really like people like you scientists to also look into this. There are masses of data available, but no one has actually looked into it. Let me also say that in the 21st century, clinicians, epidemiologists, scientists, obstetricians, pediatricians have concurred that we need to adopt a life cycle approach. The problems that we face in terms of non-communicable disease, and also the fact that today's girl child is tomorrow's mother. And that needs to be, I think, looked at with a gender bias. Unfortunately for you gentlemen in the short term, but I think in the long term, investing in women's health is extremely important for the nation. So let me highlight why I say this. The female life cycle. No doubt, we are born with our parental genes, but our environment starts from the mother's womb, and that has its impact until we go to the tomb. So basically, our genes get, their plasticity gets altered in their expression. And if you are born like either of those two babies, you are liable to obesity from adolescence. Particularly if you're a girl, you're likely, it's going to wreak havoc in your hormonal milieu, manifest such as polycystic ovary and so on, make life difficult for you to conceive easily. Not that I'm saying that every woman with PCOS cannot conceive, but it might be linked to other metabolic diseases that manifest during pregnancy and impact on the baby. So maternal diabetes, maternal hypertension all come together and impact through the placenta on the well-being of the and the quality of the fetus. And such women, even when they go post-reproductive age, they carry the burden of metabolic syndrome, coronary risk, and even if they live well into the postmenopausal phase, they run various cardiovascular risks. So let me start with a case scenario. I treat all my patients as Mrs. Sri Lanka. My first Mrs. Sri Lanka is a 36-year-old lady who is in her third pregnancy, but not having the matching number of patients as children. She has only one child. She's 8 weeks pregnant. Her fasting blood sugar, please take note, is 110. And she says, oh no, I do not have diabetes. Nobody likes to be told that they have diabetes. Now, when you look into her obstetric history, it is very clear that a couple of years earlier, this was in 2015 or 16 that I came across this lady. She has undergone a cesarean section, which I'm very, very perturbed about. Today's lady doctors and professional women go for cesarean when they should not, right? But here she has had a big baby because her mean birth weight is 2.8 kilos. So she's above the 2 standard deviation. And after that, a couple of years, many, many years later, more than a decade later, she has miscarried late, not in the first trimester, late. And that is usually, it smells of metabolic causes. And you can see she's quite obese and she's hypertensive as well. When you ask her a direct question, when you see these big gaps in babies and all kinds of metabolic disease, you ask her, we always find that we are right on our hunch. She admits that she was in the Middle East, like most of our women, which we should not be proud of, that we send our women to the Middle East to earn our money. She has gained weight. She has come back to Sri Lanka, suffered from subfertility. And in the subfertility clinic book, it is clearly noted that she's diabetic by her OGTT. HbA1c is high. And some or the other, there had been no active intervention to make her optimally controlled prior to conception. So this is the reality of what happens. It slips through our net. And although we talk about safe motherhood, no doubt, lives are probably not lost. We don't know about the morbidity. And in that sense, what I would like to highlight is the fact that pregnancy is an important crossroad from one generation to another. And this cartoon was presented by a young researcher in Salzburg when we met. We used to meet every 2 years as an international group interested in diabetes in pregnancy. And she clearly showed that investing in the female gender is so important in terms of a healthy pregnancy, because were you born low birth weight or high birth weight, you carry these risks of obesity, diabetes, hypertension, cardiovascular disease, and the fact that you produce such babies to bring about an intergenerational risk, right? So diabetes begets diabetes, metabolic syndrome begets metabolic syndrome, and why need we put that trademark on our next generation? So if we pause for a moment about pregnancy, because I was telling you that pregnancy is the main window of opportunity. Actually, a normal pregnancy is a state of maternal starvation. The reason being that whether you're fed or fasting, you use alternate fuels to produce glucose to go across from mother to baby, whether you're fed or fasting. So in fact, women get adjusted to lower maternal blood glucose in pregnancy. But the placenta, which is full of blood vessels, it's a very vascular organ, it's also an endocrine organ. It produces anti-insulin hormone. The dynamic situation, these hormones go back into the mother's circulation in larger numbers, in quantities, and can unmask a pre-diabetic state into a frank diabetic state. So basically, pregnancy is a state of, it's like a stress test, like a stress ECG to see whether you have a risk of diabetes. And in fact, what if a mother is hyperglycemic? And I had the good fortune of coming across students of Pedersen who hypothesized in the 1970s at these DIP meetings when we met internationally that the placenta, he hypothesized, transfers glucose but not insulin from mother to baby. And in fact, the fetus gets hyperglycemic, fetus has a healthy pancreas, so fetus produces appropriately large amounts of insulin. But fetus is hyperinsulinemic from fetal life. That is what we need to bear in mind. Now, if you have somebody who gets glucose and insulin into his or her system, what happens? You produce fat. Fat is laden, so these fetuses run the risk of macrosomia. And in fact, these Hercules produce more urine, so they are polyhydramnia, a lot of water, jala ulbatavya in Sinhala. And they run a risk of sudden metabolic death, where the heartbeat can stop due to altered chemicals. Very unpredictable. And even if they survive to delivery, they can have mechanical problems, particularly shoulder dystocia, where the shoulder's head comes out and the shoulders get stuck. Like what could have happened to my baby that I showed you, the big one, the red one. And neonatal hypoglycemia, when the cord is cut and the glucose supply stops, there's inappropriate insulin, risk of hypoglycemia. And I'm sure had Professor CC been around, he would have bullied and teased his students to say, you must have had neonatal hypoglycemia. Okay? So leave that aside. What we need to appreciate is, like when Mrs. Sri Lanka came to us in her late first trimester, already much of her organogenesis was over. And remember that maternal glucose at high levels in the first trimester is teratogenic. We talk about medication, we talk about chemicals, we talk about radiotherapy, lack of folic acid, but we don't talk about maternal glucose. And that needs to be borne in mind. It's not that every woman is like my Mrs. Sri Lanka, but the fact that we are at greater risk of developing diabetes. So being South Asian, being pregnant, you run a risk. Now, in coming back to this lady, we had missed opportunities. And in fact, now we cannot really give her a great assurance that she'd be free of fetal anomalies. Maternal well-being, perinatal well-being, we cannot predict. And her long-term offspring health, we cannot predict or guarantee. And where have we erred? Maybe the infertility setting is where nutrition is also, the nutrition has to be addressed. Metabolic health has to be addressed as a general rule. Many of them have obesity linked to their anovulation if it's a female cause. And in fact, we got together and wrote this. We have written it. It has been translated into guidelines, but it still does not filter down to the individuals on a 100% basis. So these are sad stories. This is despite our having an excellent infrastructure and a vertical system for maternal and child health, to which I'm sure the CC played a major contribution. We have from national, provincial, regional, and to the field level, right down to the MOH being in charge of these very important people, the field midwives who are in charge of their ladies. So pre-pregnancy, preconception, interpregnancy, to have that focus is so important. And that is something that your professional organizations can link up with others and actually push for, advocate. Now, if we look at the risk factors for diabetes, is there commonality in the gender? Are men more at risk or women more at risk? No doubt when we age, we are at greater risk. If we have family history, if we are obese, we are inactive and so on. Men run a higher risk by indulging in alcohol, smoking, etc. And they are more at risk of hypertension. I'm talking based on large data, large metadata, particularly of course from the West. But when it comes to women, physical inactivity and high uric acid, which I'm sure you can tell me more as to why uric acids go up in metabolic syndrome, and the waist circumference. Waist circumference, central obesity is a strong independent risk factor based on the Nurses' Health Study, which has been a longitudinal study in the US. Now, our data on gestational diabetes, when I say gestational diabetes, this is not diabetes of my first Mrs. Sri Lanka. These are diabetes, they were not diabetic at conception. We ensured to check them out. And then only check those who were normal in first trimester to be whether they developed diabetes. And these were large samples. Guinea sample was located in Samita Guinea, the epidemiologist, in Homagama in 2004, and Buddhika Sudasinghe in 2015-16 in Gampaha. So these are semi-urban, semi-rural settings, but you can see the trajectory that it's an exponential rise of the double figures, highly dangerous, huge public health problem that women develop diabetes. In fact, we followed them up, we looked at their outcomes, and in Buddhika study, we followed them up for 1 year postpartum. And mind you, in early postpartum, at 6 weeks, 10% of our ladies who develop GDM remain diabetic based on OGTT. So this means that we are in deep trouble in the 21st century. So if you just go back to the basics about the development of type 2 diabetes, for which obesity, inactivity plays a role, and insulin resistance, you can appreciate that if we have a defined date when we develop diabetes, the whole process started before a decade before, well before a decade. And the reasons being the process is you get impaired glucose tolerance, then you get postprandial hypoglycemia, and type 2 diabetes then emerges. So doing fasting blood glucose is probably what I would like to propose is not the best, because we like to fast as long as possible and say, oh no, I do not have diabetes. That's a natural human reaction. So the other aspect is that just being hypoglycemic is not just the high sugars, it has a huge impact on your vascular health. And that is through the oxidative stress mechanisms, as well as the fact that there's inflammatory process, cascade of inflammation, and brings about dysfunction in all vascular beds, macrovascular, microvascular. And this we knew was happening from the late 1980s with the syndrome X described by Gerald Reaven, which is now called the metabolic syndrome, where central obesity played a part, and insulin resistance, hyperinsulinemia, but also all these aspects, including endothelial dysfunction, hypertension, and renal dysfunction and leakage of albumin. And the final outcome is premature atherosclerosis, coronary artery disease, cardiovascular disease, which is rampant. So if you think about the abdominal obesity, we know about this pear and apple story. I'm sure C.C. De Silva would have said belly gediya and labu gediya or something, which meant more to our people. But the fact that we Asians have to have even slimmer abdomens, and even our dress of the sari can help us to cover all these things. But nevertheless, women in epidemiology were thought to be less at risk, but it is not so. Even in the West, the older women, they know the greater affliction than the older men. But looking at death figures, premature deaths, the total deaths of WHO figures clearly shows that in our region of Southeast Asian region, men and women seem to be, if you just concentrate on the red bars with our non-communicable diseases, and the fact that the poorer you are, the greater the risk in numbers. So we cannot really fathom as to the impact of COVID and on socioeconomic status, but we need to appreciate that things may have gone horribly wrong now, even in our established systems because of this problem. But leave that aside, still we were sitting on a very dangerous volcanic proportion problem. So the other aspect that is also has been looked at is whether, because it's a female, whether the general tendency is less aggressive treatment, or is it that their pathophysiology is different. So this has been also looked into, and though we generally feel the estrogens give protection to women, this has not been well substantiated based on the figures. Where figures are available in the West, when they looked over 30 years in the US, the men with diabetes had less mortality rates over time due to intervention, whereas in women, there was no reduction. The women died similarly over 30 years. So what was this gender specificity? And it was these three authors who really caught my attention in 2012, where I suggested to the South Asian group of endocrinologists, let's look at, and I offered to give my first lecture on women and diabetes by gathering and doing a full literature search. And you can see that diabetes forms the rock bed of all these cardiovascular risks of vasoconstriction, inflammation, and so on. And the fact that in women, there was substantive data, and I would really look to you all engaging in studies to really confirm it in our South Asian Sri Lankan women, that these factors like the onion skin tend to be more than additive in bringing down to the core of the problem of women with diabetes and their risk. Because in diabetes, what we are interested in is outcome. Pregnancy, we see the outcome fast. But in long term, we don't know what happens to them in terms of what would happen. So cardiovascular risks, their management, the revascularization process may be different. We may be treating generally that women are less likely to die, but actually they suffer and die earlier. And the pathophysiology has been found that in the atheroma, where it becomes an unstable plaque, that in a woman, it is very different the way the plaque becomes unstable to a male, maybe due to the hormones. So other fact is that they develop the problem younger. Whether it is due to pregnancy, whether it is due to socio-cultural norms, once you have had a couple of babies, you're not conscious of your figure and physical activity, maybe multiple reasons which we need to determine. Another aspect is, what about sex hormones? Now, men with testosterone are actually protected. Men without testosterone, I have the hypogonadic men who are at higher risk of metabolic disease. Whereas women, all girls have testosterone, but because estrogen comes from testosterone. But the girls with higher testosterone are at greater risk, like the polycystic ovary syndrome. So this disparity is something we have still not come to a reasonable conclusion. Is it the receptors? Is it something else that is playing a role? Same with leptin and adiponectin. And also whether the women's body sizes are smaller and therefore they cannot handle even a little increase in central obesity in terms of cytokine release, inflammation, and so on. Other is, of course, the significance of impaired glucose tolerance. If you remember, that is one of the first features in the whole story of diabetes. And the postprandial hyperglycemia in the Femina offspring study has shown to have a greater impact on cardiovascular morbidity and mortality. And the other factor is that there are independent cardiovascular risks in women only. So this is something that the Monica and the Cora studies showed, which we need to check in our own large sample studies. Next is which diagnostic test, because this is another issue. Is it fasting? How long fasting? What is random? What is postprandial? How much of carbohydrate load and so on? So the specific screening test that we would recommend from a programmatic point of view, the 75 gram fasting 75 gram oral glucose tolerance test, which is something that I'm very proud of, that the Family Health Bureau accepted, and from 2013 have a universal screening approach for pregnant women. The problem is it's only when they're pregnant, not when they are not pregnant. So that is something, and also it's tedious to do fasting glucose. If any of you have tasted glucose, it's a horrible taste. It's horrible to fast when you're pregnant and having nausea. A lot of practical issues. But the fact is that the 2-hour postprandial is probably better on a practical note, but I don't know. It has to be substantiated and validated. I'll share another story with you. I hope I'm not running out of time, please then. This is another Mrs. Sri Lanka, young woman, who was a neighbor of one of my obstetric colleagues. He had done a blood sugar, found it to be sky high, and she was very tearful when I saw her. And anyway, we convinced her that she needs to get onto insulin quickly, and we were controlling her. Then she developed a kind of a connectivity with us in the clinic, and she brought her mother. When I saw her mother, she was wasted, thin, blind. She was an amputee. She was on crutches. And when we checked her other foot, she was unaware that the other foot was actually completely rotten. So that was the truth. Mother was less than 50 years of age. Our Mrs. Sri Lanka 2 years later was 20 years, still diabetic, again pregnant, no follow-up after the first baby. Now she brings her father who's diabetic and reasonably well controlled, but the mother had unfortunately succumbed at the age of 50. A couple of years later, she's 23, she's a mother of 2, she's gained 10 kilos, she remains diabetic, no contraception, so is liable to have another unplanned pregnancy. Husband also has gained weight, the whole family is chubby, right? Father seems to be the only well controlled, but my question to you is, how has society failed this family? And if we were like horoscope readers to predict Mrs. Sri Lanka's future, both these Mrs. Sri Lankas, they will be sick, continuously sick, unknown, and they'll be running from one specialist to another in our health system, and it will be a lifetime of misery. And you can see that history is repeating itself earlier, right? She is only in her late 20s. Are we named protected? You can answer that for me, that it's not. And one of the important risk behaviors is no doubt more than even nutrition, physical activity. And South Asians are woefully inactive. And one reason is we spend long times watching television. So I think Nutrition Society has to take on a kind of television programs you do and get them to become active, as also not become, pawns of bad advertising. Nevertheless, when we go back to the beginning of this millennium, Kumudu Vijayawardhan and others showed us in the community that women are having a problem battling with obesity. And we didn't take appropriate action, right? And if you look at the global figures, the world has got larger in size, in weight, not in numbers, but in weight. If you just take the individual weight, and it's Asia and particularly South Asia that has taken the brunt, right? And no doubt women are overweight and obese, but we need to appreciate that even in adolescence, we see these features in acanthosis nigricans, which can be easily taught to school teachers and other, even the informal people, that these are alarm bells that we see in the school programs, where young girls, particularly with adolescents, develop these due to bad nutrition and bad lifestyle. So if you look at our reproduction, even if we had all the factors normal, we are meant to produce only one baby at a time. And even a honeymoon baby's chance is only 1 in 4. Because as we age, our number of primordial follicles come down rapidly. That's called reproductive aging. Now, when these young girls from their teens develop these obesity, acanthosis, their menses become irregular, they get dysfunctional bleeding, they become hirsute, they lose their head hair, they develop acne more than the usual. And when they try to get pregnant, which is usually after career studies, etc., infertility comes up, recurrent miscarriages, and the polycystic ovary syndrome has become the commonest endocrine disease of young women worldwide. And in fact, we showed with much of our data that there are ethnic variations and the South Asians take the brunt. So in fact, it is very closely linked to the metabolic syndrome. All the features of metabolic syndrome are there in these women. And with the larger data, with one of our own products from Colombo, Dr. Nirandra Kumar, we studied 25,000 PCOS women and showed that they have obstructive sleep apnea. They have fatty liver, just like the metabolic syndrome that you and I know about. And in fact, at the turn of the millennium, we showed, that was part of my thesis, that the South Asian women living in England as well as in Sri Lanka had more severe insulin resistance from a younger age. And that was very similar to the British Asian studies of insulin resistance. So in fact, even the PCOS study showed that for a given BMI, that the waist circumference, central obesity was a key to this problem. When we looked at a large cohort of over 400 of our clinic patients, we found BMI was not so much of a problem, because the cutoffs were different. I had to have huge arguments with some of my colleagues from other parts of the world. But when it came to central obesity, whatever method we used, they had central obesity. These are young women. And no doubt, those with metabolic syndrome had a higher risk of diabetes in their 20s. Unknown to them, unknown to us unless we did the study. Same with acanthosis. Even they had acanthosis in areas that were not evident in the literature. Even on their knuckles, on their face, nasolabial folds, and so on. And in fact, polycystic ovary, we don't call it a disease, we call it a condition of our time. But the fact that it has a huge metabolic overflow well into the late life is something we need to appreciate. And when they are pregnant, such people, there is a higher risk of it passing on to the next generation. So in fact, the 2018 international guidelines, they first got the complaints and the observations from the people who were affected, the girls who were affected, the PCOS self groups from all parts of the world. And what they wanted was that they should not be marginalized. You cannot marginalize and say, this one has PCOS. It has huge implications. And their quality of life, their psychosexual orientation, they have lots of issues. And that these international guidelines were presented at the Endocrine Society of the US, and the entire world has agreed now this is a priority in terms of women's health, but it should not only be for PCOS, it should be for women in general. So before I conclude, I'm sure you all are very familiar. Somebody gave me this slide, not my own. But the fact that we being human, and I think it has been shown very clearly during the corona epidemic, that our behaviors determine what kind of disease burden we carry. And we need to change to a healthy lifestyle, and we need to give healthy behaviors to our own populations. And just to highlight that in our fairly stable population, we have about women of reproductive age, about a quarter of our population, about 400,000 get pregnant, and about 4,000 of those are likely to be metabolically affected. So it's quite manageable, and we have to avoid having such extremes of birth weights, and to highlight that we need to, the female gender is the key to diabetes. Prevention is my proposal, not my own, but I represent that group that has been looking into it. I do not think that these 7th century damsels had PCOS or metabolic syndrome, but I'm sure even at that time, there might have been a few outliers, but not as much as now, because they were more healthy, more active, and probably lived with nature rather than technology. So thank you very much, and stay safe.